Senator Anderson, we can lift the
Excellent.
call on the two vote onlys. One was to adopt recommendation number 1 that the spring finance letter requesting money for some additional parole agents. The vote is 2-2.
Aye. I didn't know if you were going to ask me for the vote, so.
And the second is rejecting the Office of the Attorney General's request for 5 additional attorneys for litigation, considering that we seem to be winding down the litigation and they already have 150 attorneys.
Aye. Thank you.
Aye. So that passes 3-0 also. Thank you. Now we're going to hear from the Department of Corrections and Rehabilitation Healthcare Services. Okay, and the LAO is going to do the overview for us. LAO.
Thank you, Madam Chair. Sarah Larson with the LAO. So we're going to just start with some background on healthcare spending in the state prisons, discuss the role of the receiver, the audit processes, and the issues that will likely have to be addressed before we can exit the receivership. We've provided a handout for your reference to kind of give some background on those issues. So as you can see on page 1 of the handout, in 2012-13, the state spent approximately $2 billion on inmate health care, or approximately $16,000 per inmate. More than $11,000 of that is budgeted for medical care, which excludes mental health, dental, and pharmaceutical costs. And that's more than any other state spends on inmate health care currently.
Per capita.
Per capita, yes. And if you turn to the next page, we have kind of some details on the litigation and the federal receivership. So the Plata case that was filed in 2001 contends that California is in violation of the Cruel and Unusual Punishment Clause of the 8th Amendment. And in 2006, the court found that the care had not sufficiently improved and appointed a federal receiver, Clark Kelso, sitting before you today.
Well, not originally, but yes.
Yes, currently.
Number 2.
Second one. To oversee the prison's medical care system. And in 2008, the receiver developed the turnaround plan of action, which was approved by the court, and that functions kind of as a roadmap for achieving a constitutional level of care. That plan covers all the medical care, including goals related to access to care, quality of care, staffing, facilities, and we have some details on that on page 2 of our handout. As of the most recent update to the court, the receiver has achieved more than 70% of those goals. To exit the receivership, if you turn to the next page, the state must prove that it can provide a sustainable level of constitutional care. There's no one standard that the state can meet to prove that they're doing so. However, the court has developed several tools that it uses to monitor progress in achieving those improved medical care goals. The first of those tools, as we discussed earlier, is the OIG Medical Inspection Program. And that inspection program is based on the 2002 settlement agreement that created specific standards for constitutional care. For example, timeframes for when inmates should be seen. As we just discussed, the OIG is modifying that inspection tool to focus more on specific measures of quality. With the previous tool, the OIG had audited each institution 3 times, and the most recent statewide average score was 87%.
But that not corroborated by the Plata court evaluation.
Yes. So if you turn to the next page, we discussed the court expert audits. So the court recently ordered evaluations of medical care by 3 court-appointed clinical medical experts. And prisons with OIG audit scores of 75% or more had a chance to participate in that audit process. Despite the high OIG audit scores that we discussed, none of the prisons reviewed by the court met that standard completely. And in March 2014, the court suspended those audits. Instead, the court experts are working with the receiver to address systemic medical problems that were found in those audits, and also with the OIG to refine the medical inspection tool so that it kind of more closely aligns with what the court expert audits were doing. On the next page of our handout, you can see some of the issues that the court expert auditors identified. One of those issues that they discussed was staffing. They raised some concerns with the acuity-based staffing model that we'll discuss later, particularly at institutions with higher acuity patients. At those prisons, the court was concerned that understaffing of medical and correctional staff or high rates of vacancy led to delays in care. As I mentioned, they also expressed some concerns with the vacancy rates, which has been kind of an ongoing issue. Another issue that they identified was with the inmate transfer process. So, for example, they noted that there was not adequate space to evaluate inmates when they arrived at an institution to identify medical issues. They also noted that sometimes inmates were transferred when they had appointments scheduled, and so they would miss those appointments. And they did notice that some inmates would receive a medical test at one prison that that flagged them for follow-up care, but that they didn't receive that follow-up care when they transferred institutions. Finally, they raised some concerns with the quality of the medical care that was delivered, as we kind of discussed with the OIG inspection process. For example, they raised concerns about provider documentation of the visits with inmates, such as noting test results, inmate education, follow-up care that was ordered. They raised some concerns about the treatment of inmates with chronic diseases, and also some concerns with inmates receiving care and follow-up care within the court-ordered timeframes. One final issue that they raised was that clinical issues sometimes took a backseat to security issues. So, for example, one of the issues that they mentioned in one of their audits was an inmate remained in handcuffs when his blood pressure was taken, which would affect the accuracy of a blood pressure reading.
Yes.
So aside from those issues documented by the court expert auditors, there are other challenges to achieving constitutional level of care. One of those issues, which we'll discuss later, is valley fever. So the receiver was recently named in a lawsuit alleging that there was inadequate prevention of valley fever outbreaks. The receiver has made some policy changes to address those issues, as I'm sure we'll discuss later. There were also several issues raised with the activation of the California Healthcare Facility, or CHCF, as we'll also cover later. And those allegations included inadequate staffing, a lack of basic supplies, and that ultimately resulted in the receiver halting admissions to the institution. So if you have any questions on any of those issues, I'd be happy to answer them. Thanks for your time.
Thank you. I think those will probably come up in the discussion that we are going to have. Okay. Yeah, so we will now ask the receiver if he would give an overview. I do have a little question for the LAO, though. Did you look at the pay rate that we have for doctors, dentists, and nurses? And how does that correspond within the private sector? I've heard both, that maybe it's low and we need to pay more. I've also heard that with overtime, they actually make a huge amount of money. And I wondered if you've checked on that and what you found.
We have looked into that a little bit. I don't have specific numbers with me, but I'd be happy to work with your staff to get you those.
Yeah,
those
I think
numbers.
we're really trying to understand the extent to which compensation issues play in to what's happening. I'm also interested, perhaps the LAO could look at for us whether the department has ever thought about some kind of a loan forgiveness program for health professionals to help pay for their medical school issues, because frankly, I have to say, reading the PLATA evaluations was a very sobering and disappointing experience. After 13 years of a receivership, and I don't know, again, to what extent we have cultural issues in the workforce. I don't know to what extent it's compensation, but obviously something needs to change or we're going to drag on like this forever. So it did seem to me that it might be useful to think about bringing some young outside eyes into the system and enable more of our young people to pay off the very crushing school debt that they've accumulated.
Some of the prisons are eligible for those sorts of loan forgiveness programs, and I know the receiver does include some of those materials when they are recruiting their staff.
And that's based on the prison location?
It is, yeah. Generally, those sorts of loan programs are associated with rural or disadvantaged communities. And so I'd be happy to work with your staff to get you the information we have on that.
Thank you. Thank you. So now we're going to ask the receiver, what is your view of this, where we are now?
Thank you, Madam Chair. Clark Kelso, the receiver in charge of medical care. First, I do want to compliment the committee staff and the legislative analysts on the quality of the material in the agenda here. It's a very good summary of a very complex set of information. And I appreciate also all of the rather detailed and focused questions. It does, I think, help focus our attention as well. I see the life of the receivership essentially in three pieces. The first piece extends really from 2008 to about 2012 or so. And three major things happened in that period of time. First, as the legislative analyst has indicated, we adopted very quickly a plan to transform and improve health care and began implementing that plan June, July of 2008. My appointment was in January of 2008. And as indicated, we've accomplished 75% of the goals of that plan. The second major thing that happened during that period of time, as indicated by the reports from the Office of Inspector General, as well as by our own detailed dashboards of institution performance and patient health and outcomes, there have been substantial improvements in the quality of care being delivered within the prisons. We started the OIG measure at about 70%, 68 to 70%, and over that period of time, about 3.5 years, rose to the last average year was around 88%. And if you look at the trend line, we were crossing 90% at the end of that period. As the Inspector General has correctly indicated, and I think the legislative analyst's summary indicates, the high overall scores from the OIG instrument did have the effect of concealing 4 or 5 specific areas where our performance was significantly worse than the overall score. That essentially is what most of what the court experts discovered when they went out. I'll get to that a little bit in the future. So, second thing that happened during that first period is a substantial improvement in quality of care. Third thing that happened during that period was that we got control over what, at the time of my initial appointment, were really stratospherically increasing costs for delivering care. My predecessor had largely accomplished the goal of staffing up with clinicians. When he began in 2006, the vacancy rate in many places was approaching 60-70%. And so he managed to very quickly staff up, oftentimes with new young talent. And by the time of my arrival, we had a fairly good complement of both nursing staff and physician clinical staff. One of the consequences of that, the fact that we were delivering a lot more care, was that costs were rising really almost geometrically. and we were headed towards having the cost of medical care exceed $2.2 billion. That's excluding
Could you
mental
just say
health.
why they were?
Yes,
increasing
what was
the-
happening was we were delivering care to inmates who for a decade or two had not been receiving care. And there were no controls in place on my arrival on such things as when a physician wanted to refer someone to a specialist or out to a hospital, it happened. There was no control on whether it was appropriate to do that, whether it was necessary to do that. It was all really in the hands of individual clinicians. This was happening at a time shortly after the first receiver, and to some extent during my first year as well. We were significantly using peer review processes to weed out bad doctors. And so for the new doctors coming in, they came into an environment where it appeared to them if you make a mistake, if you get a bad outcome, you're going to get fired. And the phrase that we heard was, when in doubt, refer them out. So I'm confident what happened. There was both a real need to refer inmates out for specialty and hospital care, but then there was also an artificially generated, we're going to refer people out because that's how I protect myself as a physician. If there's a problem, it's the specialist's fault. A form of essentially defensive medicine. Now, what we did then, and that's this same first 3-4 year period, we put in place effective control mechanisms to reduce and be able to help us manage expenses from headquarters. And this has been well documented in materials that previously have been submitted to the legislature and are still publicly available. We had essentially a cost control plan. The major elements of it were we implemented utilization management systems. So doctors had to actually go through a set of checklists, essentially, of here's the condition of the patient, here's why I have to send this patient out for a specialist or for hospital care. Utilization management systems are the same thing that HMO systems throughout the country use to help control costs and make sure that the care that's being delivered is actually necessary care. That initiative, when we implemented it, probably saved us $250 to $300 million a year, and it is still saving us $250 million a year if we didn't have it. I think the second major initiative, we instituted and enforced a drug formulary program to make sure that the drugs being prescribed by physicians were the cheapest available but still effective drug to treat inmate conditions. Upon my arrival, there was really not a formulary that was in place. We've put it in place. We now have adherence around 95%, 90 to 95% adherence to our formulary. It's a very active effort, meets regularly to make sure that we're always getting to generic drugs instead of higher priced patented drugs. And the savings there have also been really very well documented over the years. So the summary of the first period is we put together a quick plan and started executing it. We dramatically improved quality of care as measured by our own measures and by OIG, and at the same time significantly reduced ongoing costs. So that first period, I think, is a pretty good one. The second period essentially began when the state decided that it was time to essentially accelerate or see if it was time to end the receivership and terminate the Plata and Coleman litigations.
And that was what year?
I'm sorry?
That was what year?
2012, essentially in 2012. That's when that was
2012.
made.
They were directed to do a transition plan.
Yeah, and essentially the problem for the Plata court was that although we had evidence of improving medical care through the OIG scores and through the data we were collecting ourselves. The parties had not agreed, particularly on the OIG scores, on what they meant. So we could show that we had improvements, but the parties did not have an agreement that 85% was constitutional. And we did hold, the court ordered the parties to meet and confer over that question. The result was clear that the parties were far apart on what constituted constitutional adequacy. At that time, the court decided it would deploy the 3 court experts that had previously been selected for the case quite some time ago, to have them go out and let's take a look at the institutions and see where we are. And this is part of this second phase where we're having the court experts now do an evaluation. Now, I think what you find in those court expert reports are a number of things. I'm going to begin by saying I was as concerned as I suspect all of you were, that on reading those reports, it appears that the physicians were making mistakes everywhere, and that the quality of care was really quite poor. And raised in my mind the question of whether, do we really have good doctors? Or do we still have the problem that CDCR previously had, that no, you just don't have good people? I asked the 3 court experts that question late last year after their reports had come in, because that was one of my greatest concerns. The court experts told me, no, your doctors actually are pretty good. So I said, well, okay, what accounts for then what we're seeing in the reports? And the response that I got back was that the problem you've got is complex but fixable. You've got doctors who are still working in a system that has significantly inadequate treatment space. As I think you can see in the reports, you've still got clinical space that is just not sized properly. We got too much big furniture in it. It's a difficult environment. You also have a situation where physicians are required to see inmates repetitively when there really is probably not a great reason to be seeing a doctor. And you can see this sort of in the numbers. You know, we process 400,000 inmate visits to doctors every month.
Where does that fall?
How many times do all of
in comparison to a large health organization or a hospital or a large clinic? I mean, it sounds like a large number, but compared to what?
Well, you know, you've got 130,000 inmates. We have 400,000 appointments a month. How many times are any of us in this room going to see our physicians during the course of a year?
Right.
So I think we are seeing lots of people quite frequently. And the concern expressed by the court experts was this has a dulling influence on your physicians. Because instead of being able to practice sort of real medicine, where you've got a planned approach to how I'm dealing with someone with a chronic condition, you're constantly churning. And you're kind of on a bit of a hamster wheel that probably can cause you not to behave at the same level of professional conduct that you otherwise would.
And the 400,000 doesn't capture return visits that the physician has deemed necessary based on.
I believe that number counts.
It does.
That does count everything.
It's new requests generated by.
Well, yes. And then I think there's a third factor in those reports that is something that I think in part we'll discover when the OIG does its next rounds. When you look through the descriptions of the errors that the court experts found, they really were of, I think, 2 sorts. One type of error reflects system problems that we still have. And those are the ones mentioned by the Inspector General and by the legislative analyst. Transfers between yards, transfers between institutions. we don't handle them very well. And we're working right now on a population care management initiative to try to address that problem. But we've got a gap there where we too frequently drop important information. That's one type of clinical error that I think you can see quite frequently in their reports. Another type of error is the one where you think, well, the doctor simply is not living up to the appropriate community standard of care. Now, I want to speak to those because there are a lot of those that are in those reports. I think it's important to recognize that the vast majority of those are what we describe in our death reports as simple departures of care. These are not huge catastrophic mistakes. They are departures of care, but they're not as significant as some other departures of care. And they are departures of care that happen commonly, even in free world healthcare systems, and probably happen more frequently than all of us really would
Care
like.
to acknowledge,
would
yes.
care to acknowledge.
Right.
Second, and I don't like to speak in terms of none, so I'm just going to say virtually none. There may be two or three. None of the incidents or failures they report clearly led to any significant injury. So when you actually look at those descriptions, the chart reviews, it's not clear to me that any of them even rise to the level of malpractice, much less a constitutional violation. So I think we have to be careful in what the significance of all of those reports were, and I know that that's an issue that the Office of Inspector General is discussing with the court experts about how do you give meaning to those chart reviews.
I simply had to say, at Corcoran, for example, they found a high number of intravenous catheter and other infections that in some cases led to septosis.
That's a bad one.
They also said a hand washing study conducted in April and May of 2013 showed that none of the observed staff washed their hands before engaging in patient care.
That's a bad one.
But again, on par, Cedars-Sinai in my district a number of years ago had the worst rating of all hospitals in the land. So I mean, so I guess what I struggle with, and one issue, I hear you in terms of what rises to the level of malpractice. The difference for me is lack of choice.
Sure.
In that they are inmates. They don't have free choice in terms of which hospital, which provider to go to.
Sure.
And so it makes it almost not an apples-to-apples comparison.
And two comments. One, first on your observation about the hand washing problem is not, that is a
It's
problem.
not right, but it's not unique to.
I agree completely with the court experts that we have a system-wide sanitation problem. And I view the sanitation issue and the cleanliness and the hand washing issue as all of a piece. How do you have a clinically appropriate context?
Setting.
And a clinically appropriate setting. Diana Tosh, who's head of healthcare for CDCR and is responsible for dentistry, she had the same experience within the dental spaces, where it took them a while to get the place cleaned up and sanitary and sterile. So she's ahead of us on that. It's clearly something that we have to do more to do. Your observation about there's a difference between free world standards and prison standards. There may well be. And part of what I'm hoping happens during this, what I now will talk about as the third phase of the receivership, because the second phase really was the court expert, state trying to litigate Coleman and Plata. Third phase is where we are now, which is the court experts have identified really 4 or 5 big system-wide issues that we are addressing with the direct help of the court experts. And in this third phase, we, I think, have to get to a point where either the parties have agreed on what constitutes adequate care, hopefully through the OIG new instrument, or the issue has to get litigated and decided. 5 years ago when I began, it probably wasn't all that important to know exactly where the line was because we are so far away from it. But we're a lot closer now. And it seems to me we need to know where that line is. And at this point, I don't think the parties are there yet in terms of an agreement. The OIG is essentially managing a process where they're going to get some comment on their first pilot report, which should be coming out sometime soon. I believe they're going to be bringing the parties back together to see what the comments are, but see if we can get to some agreement about what adequacy is. Because if I know what adequacy is, and if I've got an instrument that can measure it, we will hit it. The one thing that the first phase of my receivership demonstrates is if you give us a target, such as the first OIG instrument, our institutions can improve to hit it. Well, right now, aside from the 4 or 5 system-wide initiatives that we have underway where we know we have to fix this problem, we don't have a clear target. Without a clear target, what we'll have to do is just generally improve everything and constantly have somebody come back and say, is this good enough? And it seems to me that's really not where we should be. And it's not the best and most efficient way of winding up the plot of litigation. I think we're at a point where we're going to need to have either through litigation or through an agreement of the parties something so that everybody knows here's how you move forward to end the case. Again, we have the experience from the dental case where that is what worked. In the dental case, they were able to get an agreement between, they had 2 court experts there, the plaintiffs and the state, about here's the list of things, you do this, you're done. And as soon as the state had that list, they fixed it, and they had the court experts visit each one of them. They knew before the court experts went out they were going to pass it because they knew what the standards were. And sure enough, they marched through all 33 institutions. So that's the sort of approach that, I think we're hoping to get to in this third phase.
And I'm hoping that you will, because in any strategic plan, any project improvement plan, that's just really kind of elementary. And I appreciate you said that it wasn't as necessary 5 years ago to have that set of goals. I just have to respectfully disagree because my question goes back to, are the goals of the plan still the right goals? And that's not as sophomoric as it sounds. How do you know you got there if you don't know where you're supposed to be going? And so the lawsuit was filed, a general ruling was determined that care was subpar, but if we can't define what appropriate ideal care is in these institutions, in this department, how do we know? How do you know that your goals are still relevant?
Well, I think I do know the goals are still relevant because even with the court expert review, the things that we have improved didn't appear in those reports.
Well, when I say still relevant, maybe those goals need to be expanded because even though you met those targets, you still are also falling woefully short when, when I look at page 7 of the LAO's report in terms of valley fever and the activation problems with the California healthcare facility. I guess my point is not are they wrong, are they enough?
Got it.
Are they still the right focus and target? If we've already checked some off the list, clearly we need to add a couple more issues to the list. When we're talking about scabies. The mere thought of being locked up and can't escape scabies sends me over the edge.
Three thoughts there. We have expanded the goals.
Okay.
Because as a result of the expert reports, we now have a population care management initiative that's going to solve, among other things, the transfer problem that we have, the gaps there. The Cal PIA BCP is directly responsive to what the court experts have said has to happen. I've been trying for years to get things cleaned up. You know, at 10 or 11 prisons right now, we don't have any sort of janitorial program. So, you know, that's directly responsive to them. We're working with the court experts to implement a regular, off-the-shelf electronic medical record. That's going to be responsive to the concerns in the court expert reports about medication management.
Right, and it being
where,
there
again, we
available when
fall
you're
short.
transferred, right.
So we have expanded the goals. The other two
I have a few questions on
please.
that, too. So you've been there for 6 years. Do you have a standard of care that you would recommend to the parties?